Thank you for viewing this video to prepare for Day 2 of the Hub's second annual symposium. Along with brief bookends, the video contains 2 keynote presentations, each just under 40 minutes. This is the only pre-recording for the symposium. We posted it well in advance so you could view at your convenience. Links for keynote speaker biographies are below the video. The Hub is so pleased that Dr. Carol Hopkins from the Thunderbird Partnership Foundation and Dr. Kwame McKenzie from the Wellesley Institute and University of Toronto chose to accept our invitation. Their job is to provide perspective and ideas for helping mental health promotion flourish in Canada, the central theme of the symposium. Both speakers draw on extensive experience. For Carol, that includes leading contributions to national policy frameworks for Indigenous wellness and substance use, as well as effective use of two-eyed seeing. Kwame's emphasis is on health equity, including in the development of social policy and health systems, and including in response to the pandemic. The order of presentations is Carol, then Kwame. I return at the end with brief instructions for submitting questions for the live online dialogue with them and 3 other panelists.
Wewena Bosho, no gem indígena Kaskaye, Mainga and Dodem, Lene Lenape Kwe and Dow, Lenape King and Donjaba. I'm Carol Hopkins and I come from the Delaware Nation. The Delaware Nation is originally known as the Lenape people. We're located in southwestern Ontario. And my mother is from the Delaware Nation at Moraviantown, and that's where I'm joining you from. The community is also host to the head office of Thunderbird Partnership Foundation, where I am the CEO. And I'd like to talk to you about health promotion for children and youth from a First Nations lens, using culture as the foundation. And I'm going to share a presentation with you to speak from. I'm going to be talking about promoting wellness for First Nations children and youth. And I'm going to start from the foundation of the First Nations Mental Wellness Continuum Framework. It has 5 key themes, was developed in conversation with First Nations across the country, and it conveys the importance of culture as the foundation. So in this environment where we're talking about reconciliation and understanding our roles and responsibilities for implementing the calls to action, TRC calls to action, there's a lot of conversation about First Nations or Indigenous peoples' knowledge, culture, and practices. So we're talking in the space of health promotion. This framework is also critically important and relevant. And the one key thing that I want to convey in the presentation today is based on culture as the foundation. And so when we talk about culture as the foundation, it requires a paradigm shift, a different way of thinking, because currently or historically, we have been working with First Nations populations from understanding the deficits, the problems, the challenges, and our concerns for how do we facilitate, what's my role in engaging in supporting their health and their wellness. But it's always starting from that problem base. And then we're working to discover, hopefully we're working to discover what are the strengths that are present in the families and the communities of First Nations peoples. But what this mental wellness continuum framework is talking about is that we have to move from that place of starting on what's the problem and then trying to fix the problem, and through that process discovering strengths, almost as if it's accidental. We have to start from the place of what is the strengths that we can draw on that sets the foundation. And in the framework, that culture as the foundation theme is the discovery of strengths. And that if we are working from the foundation of culture to try and understand that culture and what it translates into practice for promoting health and wellness, then we're also working from the shift from excluding Indigenous worldview, value, and culture, and we're practicing how do we understand Indigenous knowledge, and how does that set the foundation for evidence because we all want to ensure that what we're investing in is actually going to make a difference. But and for First Nations people across the country, when they were developing this framework, they were saying, we know our culture and our knowledge makes a difference, and we have to start using that rather than always converting or adapting or modifying Western-based theories and practices. That can be meaningful and have been meaningful in making a difference, but they haven't, our elders have said, those practices alone never take us far enough in making a difference. So I'm going to talk to you about that. And then when we are thinking, the great thing about health promotion is it automatically shifts our focus from just focusing on individuals to thinking about families and communities. And in this sense, we're talking about shifting, as we're thinking about families and communities, what outcomes of our investments or efforts are making for whole of families and whole of community. And then moving from the uncoordinated and fragmented efforts and services to looking at integrated and sustainable models. And so the culture as foundation, we have to first understand, what is Indigenous knowledge? What do we mean by that? And for First Nations people, it's important to know that their knowledge is sourced from the Great Spirit. Our stories of creation talk about the ongoing relationship and in that story of creation, the Great Spirit is talked about as ensuring an ongoing relationship and ensuring that anything and everything that we would need to live life forever and all time across generations and of people on this earth have been thought of in that beginning time. And there was a way to actualize those answers in physical reality, from spirit reality to physical reality. And so in physical reality, then, we have access to that source knowledge through our teachings of creation that are held in our sacred records and writing that we find in sacred societies and translated through our original languages and culture-based practices. Now, stories, when I talk about the creation story, it sometimes puts our mind in the realm of not evidence, not quality. It's a story. Our written records, our writing and our records is also not in the same format that we understand writing and records that contain evidence of quality. Our writing and our records are in different formats: birch bark scrolls, pictographs, and symbols. And there are very few people who can read those records in that writing. But those people have been trained across generations to understand that and understand the language that holds that knowledge. But they say that knowledge is not valuable if we do not translate it into everyday life. And so that's conveyed through the creation stories. And our stories say that every creation story is true. That's different than how we understand Western-based evidence or conventional evidence, where it's always open to question and to revalidating and to retesting. And the stories of creation are different across the language groups of First Nations people across the country. But there's no debate about which stories are true. And they all have common elements. So the belief is that our culture and our evidence is visible through our language structures. And that also convey our language structures are spirit-based. And because the spirit is central to all of life, the Great Spirit is central to all of life, the spirit influences all of life. And so just some quick examples of that, and I'll talk about that a little bit more, is our original language for the land and all of creation on the land and below the land, in the sky realm and the universe, including human beings that were created by the Great Spirit, are all invested with spirit. And so all are related. And it's important to have relationship with our relatives in creation. So what does that have to do with health promotion? Well, we know health promotion, prevention, and education is about knowledge and skills, creating awareness and to help facilitate healthy lifestyles, creating the conditions to support those lifestyles, doing what we can to reduce the occurrence of harmful behaviors so that we have supportive family relationships. So from a culture-based lens, again, drawing from that Indigenous knowledge, it's critical to increase knowledge and skills for living life well as an individual, family, and community. But what informs that healthy lifestyle? What are the models and the theories and the practices that support a healthy lifestyle for families and communities? We have to start there first, is what knowledge are we drawing on? And when we look at the mental wellness continuum framework, culture as a foundation, we have to spend time in conversation with First Nations people to understand their culture and their worldview. In addition, we have to ensure that our efforts are towards increasing and supporting mental wellness equity. So it's not having those conversations so that we can take it away and then go and develop something on our own and then assume that we can offer that service for First Nations people. And a lot of people are using the word of co-management or co-development or two-eyed seeing. And culture as a foundation means that we're not just having a one-time conversation and extracting knowledge from or bits and pieces from that conversation to develop a tool, a process, a program that promotes wellness. It's about an ongoing investment in that culture and that knowledge to facilitate equity. And together then that increases protective factors, at the same time decreases risk factors, and we become aware of those as we move along in the attempts to apply culture. And we also have to understand that health promotion cannot be achieved if policies and actions do not have an understanding of the determinants of health for First Nations. And so, using that deficit-based lens, it's like, okay, so what is it that's preventing the health promotion? We can't ignore that, but we have to ensure that that isn't our only focus, and that we're not just going down that rabbit hole focused on all of those issues, but it being informed to ensure that our efforts are not placing the burden solely on First Nations people as though they are the so-called cause of the issues that they face. So we have a life expectancy that's 10 to 15 years lower than national Canadian average. There's preventable chronic diseases and transgenerational trauma that is resulting from colonial policies. And we think often of colonial policies as being something of the past, but we can't afford to fool ourselves and give us that false sense of comfort, because colonial policies today also exist, and they're policies that assume that culture doesn't matter, Indigenous knowledge doesn't matter, that our sources of evidence are not quality, and that we have to, figure out a way to work around that. And so those things lead to, and we have experienced the criminalization of our own language and ceremony and culture, and removal from our lands. Today, we experience that through floods and fires and environmental disasters. We are being removed from our lands. And our language use is, we have a new language act in Canada, but we're still trying to figure out how do we support language in policy and in program. And separating children from their families. It was once the residential school, now it's child welfare. Infant mortality rates 2 to 3 times higher with the absence of our cultural practices or the investment in in our own practices around birthing and taking care of life coming into the world, we have seen infant mortality rates higher. And then our disconnection from land has led to diabetes. We're twice as likely to die from avoidable causes and more likely to end up in child welfare and less likely to graduate high school. And so this is the current landscape. So what are we going to do differently? We have to take bold action to ensure a different course, and that's health promotion. If that's not where we want to go, then what are we going to do that lands us someplace different? Well, Janet Smiley and colleagues did a systematic review looking at what creates the good environment and evidence for investing in infant toddler health promotion, prenatal and infant toddler health promotion in Canada. And they found certain characteristics that produce results in health promotion. And those are local Indigenous community investment. That's the same thing that the mental wellness continuum framework talks about, community ownership, community program development. And where there are community perceptions that the program is intrinsic, meaning that is owned by the community because they have invested their own knowledge and cultural practices, and that there's high levels of sustained community participation when it's developed by the community for the community, and where there is leadership to ensure that the program is sustained. And the difference it makes is seen from the literature review in birth outcomes. Infant mortality rates have changed. Access to pre and postnatal care having an impact in prenatal street drug use, increased breastfeeding, dental health, infant nutrition, child development, and exposure to language and culture. All of these things make a difference, and they've seen in the literature where there is good evidence to demonstrate that. So the conclusion that the authors make in this study is that we have to demonstrate important pathways to success. And now this study is about the beginning of the lifespan. And so I'm saying for health promotion, if we're not clear what anchors our health and wellness, our mental wellness at the very beginning of life, then our investments a little bit at a time across the lifespan do make a difference, but we have to understand the foundation. Culture is the foundation. And so here are some questions we asked in another research study, and I think are important questions for what you can do as you approach health promotion initiatives with First Nations people. And the question is, what is a whole and healthy person from your lens, from your knowledge of your culture and community? What is a whole and healthy person? And most often people say or answer that question by a definition of what is not. And so they'll say, well, there's less diabetes or there's less substance use. And that's not a good definition of what is a whole and healthy person. That is another conversation that is the talking about the absence of disease. And so we have to help facilitate a shift in that paradigm shift I talked about earlier, and start from, again, what is culture in the community, and what does it tell us about what is a whole and healthy person, and how does our culture facilitate wellness? So when we practice those culture practices and interventions to promote wellness, or we invest in understanding Indigenous knowledge and where that comes from, what our language holds in for informing our perspectives of wellness, what should we expect those outcomes to be? So what is a whole and healthy person from your culture, from your language? What does your language communicate about that whole and healthy person? And how do we practice culture to facilitate wellness? Now, it's not the things only, it's not only culture is not only about the things that we do. Culture is understood as a way of life. And so that expands our thinking and our understanding about what are those ways of life, and fits well with health promotion or mental wellness promotion that facilitate wellness. It takes us and expands our perspective to family within community, and community on the land, the community within nationhood and their identity. And so when we ask those questions in a research study that was called Culture as Intervention, honoring our strengths, learning about culture as intervention, that conversation across Canada, across language groups, across cultural practices, and it was only focused on that culture as evidence, culture as foundation. What we found is that there are 13 different indicators that tell us something about wellness. The whole and healthy person is attending to mind, body, emotions, and spirit. And that, going back to that Indigenous knowledge perspective, spirit is central. And that when we invest in spiritual behavior, we're attending to learning about the values of the people, at their belief systems and worldview, and how they identify themselves and what that identity means to them. It creates a sense of hope because it's grounded in their worldview and lifts up that identity rather than trying to erase it. And emotional behavior, emotional wellness is facilitated by relationships with family, community, and all of creation. And when we have those things in place, it facilitates an attitude towards living life rather than in a place of despair where the determinants of health around us are barely seen as equitable or supporting our wellness and our overall health. And when we get to those places of despair, that's when we find high risk for choosing to step out of this life, and otherwise known as premature and unnatural death or suicide. And mental wellness is taking our spirit-based knowledge, that intuition, because we have a spirit, and that spirit is always influencing our thoughts and our feelings in relationship with the spirit around us. And so we're taught, when we have access to this knowledge and it's supported in the environment around us, we use the English word of intuition. And then we're matching that with the physical reality, education and learning experience. And together those two inform a fuller understanding about my life has meaning. And finally, then understanding my life has purpose. And understanding physical wellness is about ensuring that we are facilitating the unique ways of being and doing of First Nations people. And when all of those things are in place, it creates wholeness. And so we created an assessment to measure the impact of culture on achieving those outcomes. And you can find that on our website. And I'm going to talk to you in a minute about those results that we've achieved. But earlier I said that sacred knowledge has to be translated into Indigenous knowledge through language and cultural practices. Peter O'Chese was a great elder, and he talked about the stages of life. But what he was talking about is the spirit journey through the stages of life across the lifespan. And that teaching was all about facilitating cultural practices and an environment that would support the spirit journey and those spirit openings that happen at different stages of life that are critical to our wellness. And so I said earlier, language is the foundation to health promotion. So I'm going to start giving you some examples now that I think I've introduced a foundation of a way of thinking about approaching health promotion. So our language is the Ojibwe language. It has a term called manadomenes. And that concept is as a whole concept. You can literally translate manado as spirit, and menes, and the contemporary interpretation is beads. But that has much more meaning than spirit beads. What does that mean? And originally, it was our way of communicating an understanding about physical and spiritual life together, and the seeds of life, and the way they're strung together by the Great Spirit. And so those spirit seeds translate into an understanding of our DNA. And so those spirit seeds are strung together physically and spiritually, that make up our unique identity. And from that comes our understanding of our nationhood, our name, our language, as well as our personality, characteristics, strengths, gifts, and our connection to creation. It's all held within the link, just in that one concept. And so if we understand, if we take time to invest in understanding how our language can inform our way of thinking and an approach to health promotion, then we have an understanding about what will facilitate those different outcomes than we talked about earlier. And so here's another example about how that was translated into practice. And so the way that this Tikanagan and this moss bag are held together is not given much priority. It's the dressing up, the beadwork, and we say, oh, wow, that looks beautiful. All of it has meaning. And the meaning of it is the dressing up and the symbols represent a culture, a nation, and their way of communicating. And so our written records were in beadwork patterns that translate an understanding about identity. And what was understood is that the environment around us, the community, our relationship with creation and the land is critically important. And so in the way that we took care of our newborn babies was that we dressed them up so that their identity was seen and was visible from the very beginning. And so the beadwork might represent their spirit name. It might represent their something, well, it does represent something about their culture, but it also might communicate something about their clan. And then the lacing represents that DNA string. And from a First Nations perspective, Manadomenes is not only the physical DNA, but the spiritual DNA, and the understanding that everyone in the environment around this newborn baby is responsible for dressing up the spirit to ensure a good life and life to the fullest. And so this is a picture of my grandson, and he tried really hard to come into the world early, and he was very successful. He came in 10 weeks early. And so there was a lot of concern about, his life, and would he be able to make that journey into this world safely and live. And so there was lots of ceremony and cultural practices to petition the spirit for that support to his clan, and his family and community around him that came to support his mom when she was in hospital, waiting for, hoping to have him in her womb as long as possible. And then when he was finally able, he made it, obviously, and when he finally was able to come home, then it was important to connect him to creation and to say thank you that he has arrived. Now, that doesn't leave out the Western medicine and the great hospital that ensured they did their part in supporting my daughter and my grandson and his father, and making sure that he arrived. But it was both sides, and the Western knowledge, medical knowledge, and our cultural sacred knowledge that ensured his arrival. When he came home, then it was touching his feet to the earth for the first time. And so when we lowered his feet, there's lots of meaning in the lowering of the feet, lowering to touch the earth. And it represents a portion of our understanding of our story of creation. When he touched the earth, his feet and his reflexes automatically pulled his feet back. Now I've cropped this picture, and what you don't see around him is all of his cousins and extended family who came then and gently put their hands on him to help him touch the earth. And now you can see in this picture, his mom has lowered him to the earth and he's comfortable. But it was with that support of family and community that also ensured his life, the promotion of his life, that he was able to achieve and live life. And so on this Tikanogan, it's laced up a little bit differently, but the dressing on it represents his clan. So Indigenous culture is what has sustained us as a people. It didn't disappear. Our language didn't disappear. Our knowledge did not disappear. And thank goodness that we had our ancestors who found ways to ensure it for the future in very practical ways, practicing our culture in ways that were out on the land where they would not be seen, and our children would not be confiscated, or whether it was hiding those sacred records in the land, and all of those efforts, as well as their prayer and their beliefs, ensured something for the future. But in Maslow's study, when he was studying Blackfoot people, and from that study, he developed his theory on his model on the hierarchy of needs. He found that the settler nations around Blackfoot communities had far more psychological distress than the Blackfoot people. And when he studied that, it's represented in this picture. That child is smiling, and his study understood that relationship with his mother, with the community around him, but also how they cared for him, ensured that that baby was content. Again, setting the foundation for health and promoting health. So that was criminalized. But yet today we have these mechanisms that, showing the picture of another baby smiling, that attachment, these mechanisms, the child carrier, it's for convenience, but it also facilitates attachment. And so we have to think about how our cultural practices are reflected in reality today as First Nations people, but our partners and our allies also have to understand that we had these practices and they have not disappeared and they're still relevant today. So I'm gonna move on to understanding youth then. So our cultural practices at the youth stage of life, and again, this goes across cultural diversity, but is fasting. And fasting is about igniting those spirit seeds. Again, across the lifespan, across the stages of life, there are critically important teachings and practices that are about attending to the spirit. And so at the adolescent stage of life, if you look up anything on the internet or have understood anything about culture through your conversations around youth and adolescence, there's a lot written about the rites of passage. And the rites of passage have to do with becoming a woman for the first time or becoming a man. And there are significant markers of that change, that physical change, but also the spiritual change. And so it's about igniting that spirit and developing, feeding the spirit. And so fasting does that. And in practical ways, it helps us to manage our fear of the unknown because you're out on the land in isolation for a period of time. And you're there day and maybe overnight. And so if you think about a teenager, maybe they're a little bit better able to manage the dark, but you don't just start fasting at the adolescent stage. You begin with teaching and preparation so that when they get to that adolescent stage of life, they know how to manage their fears of the unknown. They know how to manage their emotions. Now, this is a significant issue for many issue. I mean, it's a learning opportunity and it's a challenge because we're trying to develop that emotional intelligence and emotional regulation. And that's what fasting does. It also teaches delayed gratification because you're fasting for a reason, for something. So you're petitioning your spirit family, all of creation, the Great Spirit, to help you to see and understand more about your purpose in life. And that's the vision, to have that vision about what is the meaning and purpose? How do I fulfill that? And then the social responsibility is that you're not doing that in isolation, you're doing that with family and community. And so that's one example of a cultural practice that prepares and then facilitates an understanding about one's purpose and meaning and connection and relationship to family and community. And so without that foundation of culture that promotes wellness, promotes health, then we have a loss across the stages of life that then just continue to accumulate. And so before birth, we know intergenerational trauma is transferred from generation to generation, and so is addiction. So pre-birth, we have the presence of that trauma and addiction and the impact on the unborn. And then when they're born, we know through the Canadian Human Rights Tribunal that focused on child welfare, that child welfare plays a key role. And so when the children are born, they're more likely to be picked up by child welfare. And that interrupts the production of oxytocin that facilitates bonding and attachment. But it also, it creates those neurological disorders that we see in autism, for example, Asperger's. Those kinds of conditions are not just genetic, they're environmental. And at the adolescent stage of life, that appearance of trauma, it manifests in behavior. And the underlying trauma experience that continues to happen is sexual abuse. And then when we get to that young adult stage, instead of wandering around trying to figure out how do I fulfill my purpose and meaning in life, people are not able to find answers to that. And then they're choosing to step out of this life. And then when we get to that stage of I've wondered about life and how to fulfill the meaning and purpose of my life. And now I understand the truth of that, what I'm going to take from this world around me and what I'm going to bring along from my family and my culture. There's a lack of education because our environment around us and our relationship with Canada has worked to erode that connection. And so the truth of our life is interpreted as I'm in this situation where I have all of these deficits, and that must be because I'm First Nations. And so we internalize that oppression, and on it goes. We have opportunity to change that. We live in an environment in Canada that is one of promoting reconciliation, promoting an understanding of First Nations, and promoting an understanding about our rights. The UN Declaration on the Rights of Indigenous People speak to the right to practice health and wellness from our own culture and our own knowledge. And so I thank you for the opportunity to share with you today. Hopefully, I've given you a foundation of understanding culture as the foundation, and how that is realized in our practices that work to promote health and wellness. Chimikwich.
Hi, my name is Dr. Kwame McKenzie, and I'm going to talk to you today about building a better pandemic response by filling in the gaps. And I like the idea of filling in the gaps because I was brought up in London, England. And if you're on the subway, which they call the tube in London, England, when you're getting on or off the tube, people say, sometimes shout, mind the gap. This is over the tannoy. They say, mind the gap. And the reason why they say that is because there's sometimes a gap between the train and the platform, and people fall down the gap between the train and the platform. About 300 people a year do that. And I started thinking, well, why is there a gap? Well, there's a gap because sometimes, and you can see on this image, that some of the train stations, the actual platforms are curved. And so if you've got a curved platform and you've got a straight train, some parts of the train, some parts of the carriage are further away from the platform. That's why you have the gap. Now, there are loads of things you can do. There are actually loads of strategies for filling in the gap. Say, for instance, you could straighten those platforms. But the tube, the London Underground, decides that's not what it's going to do. Instead, it's going to transfer the responsibility to the individual by saying, mind the gap. And so it's your responsibility to make up for what is an actual structural issue with the tube. And I wanted to use this idea of these structural problems which we really should deal with structural policy rather than individual responsibility, to think through some of the things that are happening in the pandemic, some of the gaps we have in our policy making, some of the gaps we have in our strategies. And so today I'm going to talk about 4 things really. Talk quickly about COVID in Canada, then talk about the first gap, which is about implementing pandemic equity strategies. Then I'm going to talk about mental health and COVID, and I'm going to follow that by talking about a gap which I think is important, which is the need for a mental health promotion strategy for COVID-19. So, COVID in Canada. You will know that there have been about 3 million cases to date at the time of this recording. There have been nearly 34,000 deaths, and there are 150,000 plus cases of long COVID. Difficult to get the numbers. 150,000 is probably the minimum. And you'll see on the other side of this slide that there's significant variation in reported COVID death rates per 100,000 for the different provinces, and also on reserve First Nations. So very, very different. Now, we don't know how much of this is differences in reporting and differences in counting, but we do know that at the moment there are reported differences. And one of the reasons we sort of expect reported differences is we know that for every illness there are different determinants of health which act differently on different people and different population groups. So this slide is from the Canadian Medical Association, and they did a piece of work called What Makes Us Sick? And what they tried to do is they tried to quantify the proportion of illness that was caused by different things. And they came to the conclusion that 50% of what makes us sick and 50% of what stops us getting better is our lives. So income, early childhood development, disability, education, being a member of the indigenous population, your race, employment and working conditions, your food, safe and nutritious food, housing and community belonging. So 50% of what makes us sick is our life. 25% is our access to healthcare and our healthcare systems and wait times. 10% is our environment, air quality and civic infrastructure. And then 15% is physical, our biology, our genetics. So 85%, 50% your life, 25% your healthcare, 10% your environment, 85% are what people would call social determinants of health. And of course, in a pandemic, social determinants of health are even more important because our public health becomes even more important. And those social determinants interact with COVID-19 to make greater impacts in certain populations. The older people, and you'll say, well, no, that's physical, or populations with pre-existing health conditions say, no, that's physical. But actually, it's been demonstrated that we can significantly decrease the risk of death in older people or people with pre-existing health conditions by good public health. So yes, there's a physical component, but the excess deaths are significantly due to social determinants, as they are in ethnic minorities, homeless populations, institutional settings, and specific working environments. So it's really important to think of there's the difference between risk and what happens, and your risk of an illness might be due to your your frailty or pre-existing conditions, but whether that leads to death, or even contracting COVID, depends on a lot of what happens in the public health realm. And now I'm going to have two slides just to indicate how different things can be. So these are two slides, one from Ontario and then one that's from Toronto. And this is just showing the impacts of COVID-19 in Ontario for different racial and ethnic groups. And these are age standardized per capita rates of infection and severe outcomes from June 2020 to April 2021. And Ontario had collected individual level race data, so it was able to do these calculations. And what you see here are 4 different outcomes, whether you're a case of COVID, whether you're hospitalized for COVID, ICU admissions for COVID, and fatality from COVID. And it looks very complex, but really these are here just to show you one thing. At the bottom of each one of those bar charts is the rate of infection or the rate of the outcome for the white population. And it's significantly smaller than the risk and rates for all of the other racial groups, racial and ethnic groups. And so there's huge variation between the white population and different racialized groups, but then also between racialized groups, just showing how there are these differential impacts of COVID. And this is looking at hospitalization for COVID based on household income. And what you see to the left is that if you're a household living in poverty, less than $30,000 as a household income annually, you have much higher rates of hospitalization compared to the average. Whereas if you're in a household where you've got $150,000 or more as an income, you have much lower rates of COVID-19 hospitalization. And actually, the people who live in poverty are over 12 times more likely to be hospitalized with COVID than people who are in a household where they have $150,000 or more. So we've got significant inequities in COVID by a number of different measures which are due to the social determinants of health. But we also have strategies to deal with them. So this is one that was produced by the Public Health Agency of Canada, and it was sitting in the one of Theresa Tam's reports, and it is a model for producing pandemic equity. And what this model says, it looks very complex, but really what it says is if you've got the COVID-19 pandemic and you want equity, you can improve the crisis response, which is the blue box, and you can increase the social determinants of health and the functioning of our health and social care system and government, which is what you've got in the big orange box. So they're saying for the pandemic response, in order to move towards equity, you can innovate, so rapid innovations of existing systems, or you can produce new public health actions. But in order for those things to lead to equity, you also need to focus on economic and social security and employment conditions. You need to look at stable housing. You need to look at health care and the social service system and education systems, and you have to produce equity and environmental stability. So all of these things need to happen to get pandemic equity. And it sounds complex and it sounds theoretical. And so what I wanted to show you is an example of where somebody tried to do it. And this is in Toronto. And Toronto had collected individual level data, and they were able to show that some communities and some racialized groups had much higher rates of COVID than others. And so they went to racialized groups in summer of 2020 and said, well, what can we do to make our pandemic response better? And racialized groups came up with three things. First, improve the public health response. Second, here are some actions on the social determinants of health that would help. And third, they wanted culturally appropriate multilingual counselling to decrease the tension that there is in households. And so when they were talking about community appropriate public health responses, they talked about community-based multilingual public health campaigns. They talked about community-based testing and pop-up testing. They asked for free masks and sanitizer. And because overcrowding was a problem so that people couldn't socially distance, they were looking for free voluntary isolation sites. But they thought that that was not sufficient and they actually needed action on the social determinants of health. And the sorts of social determinants of health they wanted action on was on eviction prevention, on food security, on emergency childcare, and on giving access, digital access, because everything was going online. And so this is what they asked for, and this is the response that Toronto started bit by bit to build with community health centres and with communities and with volunteers and also with some provincial money. And this was the outcome. So what you've got here is you've got rate ratios of COVID-19 between June and December 2020. So these are the rates of COVID-19 compared to the white population. So they're actually measuring inequity for four groups here. And so we're looking at the Latin American origin group in Toronto, the Black population, the Southeast Asian, and the South Asian. And so if we just follow, say, for instance, the Black population, which is the second line down, you can see that in June, the rate of COVID was 6 times the white population. By July, it was 8 times the white population. And in August, it was 9 times the white population, which is when a number of these community-based, equity-driven policies started being started. And then you can see the rates come down and down and down and down until you get to December, when the rates are twice that of the white population. So at their height in August, 9 times. By the time you get to December, twice that of the white population. And still inequities in place, but inequities have decreased. And in fact, if you look at all of those populations, the level of inequity, the rate ratio compared to the white population, was lower in December 2020 than it was in June 2020, sort of indicating that something was going on, and maybe this equity focused, community driven strategies were actually efficacious. They were actually decreasing inequities, and that's what it seems was happening. However, though we've been able to show in these data and in other places in the world that you can decrease inequities, there is no jurisdiction that has a properly funded, right-sized, equity-based pandemic strategy. And because of that, because we haven't implemented proper equity-based strategies, properly resourced, proper comprehensive strategies, we continue to have bigger inequities in COVID-19 in Canada and in various jurisdictions in Canada than we need to. Let's talk about mental health. So everybody will tell you that there's an echo pandemic, some people call it, of mental health problems in COVID. And that's because COVID seems to increase the rates of mental health problems, as well as psychological distress. And there are at least 4 reasons for this. There's a direct impact of disease. So people who have a diagnosis of COVID have a 30% chance of getting a diagnosis of a mental health problem thereafter. There's also the fact that the disease kills people, and therefore that increases grief and complex grief, which are psychological issues. And then, of course, there is the links between having a serious illness, and serious illnesses sometimes increase people's relapse of existing mental illnesses. So there's a direct impact of disease. Then there are the impacts of the public health measures. If you, from increased loneliness, social isolation, and then others, increase impacts from lockdowns. So being locked down with your family, there's increased rates of domestic violence, increased rates of substance use, as well as other factors which have come because of the anxiety because of the public health measures. Then there's a question about availability of medical care. Decreased available of cancer care leads to anxiety. Interruption of other treatment can lead to worsening symptoms and psychological problems because of that. And if you have an existing mental health issue and there's a decreased availability for your mental health treatment, that could increase the likelihood of relapse. But one of the biggest factors on top of the public health measures, are the impact of economic changes. So financial worry is a potent reason for increasing anxiety and depression. The changes, the economic changes that there have been, and the economic uncertainty are linked to increases in mental health problems. So these ideas of a eco-pandemic are linked to wellness problems, languishing, stress, performance difficulties in study at work, substance misuse with increased use of substances interacting with toxic supply to increase opiate deaths, say for instance, and then new mental illness and a relapse from existing illnesses. And just to give you just one example of this, this is the percentage of Canadians who say their mental wellness has been worse or substantially worse since the pandemic. And this is data from August 2020 through to April 2021. And what we've got is just the dates at the end of these different waves of Statistics Canada surveys. And you can see that by the time we've got to April, with 42% of Canadians say their mental wellness is worse since the pandemic. And even though these things go up as we come into new waves of COVID, and they go down as we go through the waves, they still, even when they go down, we're still at 30% of people who say their mental wellness is worse since the pandemic. 1 in 3 people. And we have had a number of strategies to try and deal with this. But interestingly, all of the strategies have been about giving help or support to people when they have developed problems. So we've given online self-help. We've increased the number of helplines and crisis lines. We've increased access to online treatment, such as cognitive behavioral therapy for depression and anxiety. We ourselves have had different public organizations come and saying, all of our staff are dealing with people who are distressed all of the time. And so we've offered mental health literacy training, as have others like the Mental Health Commission of Canada and others, for public servants to try and help public servants be able to support people. Obviously, we've seen charities and third sector organizations increase their ability to do mental health supports, as we've seen some cities try and retool to give more mental health supports. And there have been various strategies which have been developed to treat problematic opioid use. And on top of that, with the increased amount of work, plus all of the stresses in the hospital sector, we have also seen increasing support for mental health service providers. So there's lots that's been done and lots of money that has been put into mental health, thinking about what we need to do to improve mental health during this pandemic. And as you know, there's government strategies that are being developed to increase the health transfer to provinces and the mental health transfer to provinces to deal with this increased need. But there's a gap. And I flagged this right at the start. There's a gap, and there's a gap in our pandemic strategy that we need to think about. Because we focused on treatment of illness, and we focus on supports for distress. But we've not focused on wellness, psychological wellness. We haven't focused on building resilience, and we haven't focused on stopping people getting ill. And when you're thinking about mental health promotion, you're thinking about what it is, building on strengths, building resilience. You're thinking about dealing with the social determinants of health, so making environments in which people can thrive. And you're talking about equity. Those are things we haven't focused on when we've started thinking about what we need in order to build a recovery, build a proper recovery. Because most of the needs that we have, the vast majority of needs that we have from a mental health perspective, are not for people who are mentally ill. Now, we really do need more supports for people with mental illness and mental health disorders. We really do need a much more comprehensive system. But the pandemic has actually also grown the number, 1 in 3 to 1 in 4 people who are distressed, but possibly the minority of them have a mental illness. And so going forward, when we're thinking about the recovery, when we're thinking about what people need, we need to think about mental health promotion. And other people have already been thinking about this. So early on in the pandemic, this is a book that was produced by the World Health Organization. And this is for children. And it's about how they can protect themselves from coronavirus. But there's this whole section about how to manage difficult emotions when confronted with new and rapid changing realities. So how you can equip yourself to be resilient, what that looks like. There's actually pamphlets that were produced by the WHO right back at 2019 to think about this, about how kids respond to stress, what parents should think about, how parents should speak to children, even this idea of having routines and decreasing the amount of negative news you take in order to build an environment for thriving. These things have been thought through. There's an evidence base in mental health promotion, and you've probably heard this idea of 5 a day. You can see on the right side, 5 a day of fruit and vegetables, which is your heart health. But there's also 5 a day for positive mental health. So if you want to have positive mental health, better mental wellness, and more resilience, they talk about doing 5 things: connect, be active, be aware, get involved, and give. Connect, stay connected with family and friends. And when they say connecting, texting, by the way, doesn't work as well as face-to-face or Zoom or ringing somebody old-fashioned on the phone. That works much better in making people feel connected and is much better for your mental resilience. Exercise and being active, very good for your mental resilience. Be aware, mindfulness, gratitude, being able to enjoy everyday things, really, really important for your mental health. Get involved is actually about learning something new. So getting involved in a club, take a class, learn piano, do something. Yeah, that getting involved changes your mind, builds your mental health resilience. And then last but not least, giving back to your community. Volunteering moves your brain into a different position completely. And it's really good for your mental resilience. So these 5 a day are individual things we can learn. But from a policy perspective, the question is, how do we promote them? How do we create policy environments that help people connect, that make it easy for people to be active, that make mindfulness more possible, that promote getting involved and continual learning, and that allow people to volunteer and give back? how do we think that through? Why didn't we start thinking about giving people this sort of advice in the early stages of the pandemic to help people build resilience? Why didn't we give them opportunities to get involved in the pandemic in different ways, so that rather than being victims, you could be much more part of the solution? So there are all of these things that you can think about, how mental health promotion can link to link to a pandemic strategy. And we did one of the biggest mental health promotion interventions ever. It's called the SERB, and there's quite a lot of evidence that that release of worry that was the SERB for low-income people, from people who'd lost their income, decreased the risk of mental health problems, anxiety, and depression in low-income people. And when government starts thinking that way, not just we're giving money, but we're actually thinking about wellness, and we're thinking about what we can do to create wellness, then I think you get into a different way of thinking about a whole of government approach to wellness and mental health promotion. And some people are doing this. This is from Scotland, and I'll leave this online so that people can have it. It will be on the Wellesley website. But Scotland has something called the National Outcomes Framework. This is what Scotland is trying to work towards as a country. This is its government's outcomes framework, and it is based on well-being. And it is specifically says it's based on well-being. It specifically says that the government is producing national outcomes built on the theory of well-being. It's actually a whole government approach to mental health promotion. Children and young people want them to realize their full potential. Communities, they want them to be inclusive, empowered, safe, and resilient. Culture, they want it to be diverse, vibrant, and enjoyed and expressed by everybody. They want their economy to be competitive, but inclusive and sustainable. They want people to be educated, but also able to use that education to contribute. They want to enjoy, protect, and enhance their environment. They don't just want work, they want fair work and business and quality jobs. They want to be healthy but active. They want to protect and fulfill human rights so they can live in a non-discriminatory environment. They want a positive contribution internationally, and they want to decrease poverty by tackling increased inequities. And this seems aspirational, but they actually have 81 indicators so you can map how they're doing. So not only is it words, but it's words with an actual measurement and transparency, so you can see how your country's doing. And that whole fact of getting people to be part of the solution, to be able to see the solution, to be able to work towards it and to understand what's happening is part of the way you create an environment where people can thrive. And so this is really interesting what Scotland is doing. It's very interesting as a framework for mental health promotion. But we need our own. And so this is why a group of organisations spearheaded by the Wellesley have been arguing that we actually need to, when we rebuild, that we need a mentally healthy Canada. And so we have been talking about the need for a social contract for a mentally healthy Canada. We have identified that COVID-19 has exacerbated inequities, which were long present, but that the Canadian spirit is ready and willing to overcome the new challenges. And we have to harness that spirit and rebuild our society and institutions in a coordinated way. We have highlighted the fact that COVID-19 is a mental health emergency that requires an urgent response, but it needs to be a true social contract between all parties. So the public sector, civil society, the business society sector, all have to work together if we want to move forward. And we want commitment. We think it's time for us as a society to commit to a new agreement, maybe a 10-year mental wellness strategy, which is based on the theories of mental health promotion, which involves government, civil society, and business that focuses not just on mental illness and mental health, but mental wellness, which takes an equity approach, which includes people with lived experience in all aspects of the planning and delivery, and really emphasizes resilience across all parts of our society, and particularly for groups that need our help most. And that means that we do actually need a mental health and wellness system that's funded to adequate levels to meet our needs. We need to focus on the workforce and the workplace and make sure that those workplaces keep us healthy. When we're thinking of substance misuse, we have to think of a comprehensive public health approach to substance use policy. And we have to think about our children who are going through a difficult time at the moment. We have to think of their physical health. We have to think of their mental health. We have to think about their emotional safety. And we have to think about the social determinants of health, because adverse childhood experiences are exquisitely linked to mental health and health outcomes in the future. And we have to think of things like poverty and chronic homelessness that we should get rid of now, and as an emergency if we're going to build a better Canada going forward. So what we're saying with regards to mental health promotion is very much as we've been saying for other types of equity. There are things we're doing that we should do better, and we should make sure that we do it in an equitable and effective way. But we also need to look at the 85% of things which we have trouble with, which are the social, which lead to us into trouble, which are the social determinants of health. And if we don't focus on the social determinants of health, if we don't focus on those social factors, if we don't focus on building on our experience and our strengths, if we don't think about equity, and if we don't think about wellness and thriving, so if we don't think about mental health promotion, it's going to be really difficult for us to rebuild and have a resilient population coming out of this pandemic. So it's simple to me, because when I was a kid, one of the things that after a while, when you're sitting on the tube and you're hearing mind the gap, mind the gap, mind the gap, it's really difficult not to sit there and think, why don't we fill in that gap? And that's what I'm suggesting that we need to think about for mental health, and therefore mental health promotion in COVID-19. Thank you very much.
That concludes both keynote presentations. Lots of fodder for the online dialogue with Carol, Kwame, and 3 other panelists at session 2B in the Symposium program. Before you sign off, please take a few minutes to consider questions for the panelists and follow the link in the description below the video to submit your questions. All questions are welcome to clarify some of the points you heard, to build them out further, to add something new. Once you've submitted your questions, click Done Sharing and take a moment to rate a few of the questions posed by other participants. Easy, quick, and informative. The highest rated questions will be addressed during the panel. Sincere thanks for your preparation. We look forward to your participation in the panel discussion.